Hello, everyone. Welcome to yet another episode of Young India Intensivist. So today we'll be listening to Ms. Tarika Sharma, who is an associate professor of College of Nursing in Aiims, New Delhi, and she'll be talking about administration of IV antibiotics, IV fluids, and blood products. We welcome you.
Thank you, Dr. Monalisa. It's my privilege to be on board today and to talk about very important topic that is IV fluids, antibiotics, as well as the blood products. So before I start, I just want to share my screen. Just let me know whether the content is visible or not.
Yeah, it's visible.
It's
Just,
not
yeah,
visible. Okay.
yeah, it is visible.
Okay. So I'll be talking about three things today, and we'll be starting with the intravenous fluid therapy first of all. We know that intravenous fluid therapy is one of the most common interventions in the acutely ill patients. The studies have shown that over 20% of the patients in ICUs receive IV fluid resuscitation, and more than 30% of them receive fluid resuscitation during their first day in the ICUs. We have also seen that these IV fluids are required to maintain the hydration, and also they are used as diluents for the drug administration. The intravenous fluid therapy is the collaborative work of the healthcare professionals, specifically the nurses as well as the physicians. And the nurses, because they are the integral part of the patient management, they should be knowledgeable enough about what to do and what not to do regarding the administration of IV fluids, so that we can promote the patient safety and we can enhance the patient outcomes. So before I start about the IV, IV fluid therapy, we should know about the indication of these therapies. So basically, IV fluids may be given for three main purposes. That is for the resuscitation purpose, for the replacement purpose, and for the maintenance purpose. When we talk about the fluid resuscitation, suppose a person is having a low blood pressure. Definitely, we have to maintain his blood pressure with the help of providing him the resuscitation fluids. Then the persons who have colon clammy skin, the person is going into shock. Definitely, we have to revive the patient with the help of IV fluids, and those fluids will be a part of your resuscitation fluid management. Then the other part of indications comprises of replacement fluids and the maintenance fluids. Replacement fluids means if a person has hemorrhage, or the person has severe bleeding, or the person had trauma, and because of which the person had bled severely, for which we have to replace that blood with the help of either fluids or with the help of blood products or with the help of colloids. So it can be the replacement is important. Same way, if the patient has vomiting or diarrhea, because of diarrhea, the person has lost the fluid, which has to be replaced with the help of replacement fluid management. Then comes towards the third indication, which is maintenance fluid management, where the fluids will be given in order to maintain the physiological balance of the persons, because the patients are there in the hospitals, they might not be able to have proper intake of the fluids also. They might be having some kind of fluid losses also. To maintain that fluid, we'll be providing the maintenance fluid. So it is important that we are keeping in mind these three main indications of the fluid therapy. So let's quickly revise about our basics. That is the compartmentalization of the fluids. We know that we have the human body is comprising of 60 to 70% of the water weight only, the fluids only, which are there in the intracellular as well as the extracellular space. When we talk about the intracellular fluid, around 60 to 63% of the fluids is there inside the cells. When we talk about the extracellular fluids, about 37 to 40% of the fluids lies in the extracellular space. When we talk about the extracellular fluid compartments, we have the fluids in the interstitial fluids also. Third space is also like we call them at third space also. Then we have the fluids in the plasma, the fluid in the lymph, and then we also have the intravascular. That the fluid in the intravascular space is the fluid in the plasma. Then we have the fluids in transcellular fluid also. So basically, it is important because the replacement will depend on these two main compartments of the fluids. Then, when we talk about the types of fluids, broadly we can divide the fluids into crystalloids and the colloids. So, usually, when we start with the fluid management therapy, we start with the crystalloids. But in some of the patients, we also have to go towards the second line of management, which is by replacing the colloids, by providing the colloids to the persons. So let's see the difference between the colloids and the crystalloids. When we talk about the colloids, they include albumin, dextran, or HES, which is your hydroxyethyl starches or the gelatin. When we talk about the crystalloids, they include hypertonic solutions, and the isotonic solutions. Colloids are the large molecules that stay in the intravascular space for a longer period of time. But in contrary to this, the crystalloids are the small molecules that they don't stay in the space for a long period of time. And the colloids are also known as plasma volume expanders because they are expanding the intravascular space at a very fast rate, and usually they are being administered at equal amount to the amount which has been lost. When we talk about the crystalloids, we need to provide high amount of the fluids because they are not equivalent to the amount of fluid loss. So we need to increase the amount of crystalloids, and because of which the person might be having the volume overload or the edema. There are various risks associated with the colloids. That is, the person might be having allergic reactions, the person might be having coagulation problems, but usually the crystalloids are safer and they don't have much complications. Colloids are costlier as compared to the crystalloids, and because of these differences, we prefer always crystalloids, and then in some cases we also go for the colloid solution. So when we talk about the crystalloids, like we have discussed, we have the hypotonic, isotonic, and the hypertonic solutions. This is depending on the tonicity or the osmolality of the fluid. So if any fluid which has the same osmolality of the blood plasma will be a part of your isotonic crystalloid. Usually the osmolality of the blood is around 275 to 290 millimole per liter. So the isotonic fluids have the same kind of osmolarity as of the blood, and the examples are your normal saline solution or the ringer lactate. Normal saline of 0.9% and ringer lactate are the examples of your isotonic solutions. When we talk about the hypotonic crystalloids, they have the less osmolality as compared to the plasma, and the examples of hypotonic solutions include 0.45% of the normal saline. When we talk about the hypotonic crystalloids, usually the osmolality is more than the blood plasma, and the example is DNS solutions or 3% normal saline solutions. So this is how these three type of solutions works. When we talk about isotonic solutions, because they have the same solute concentration as of the another solution, so they will be leading to the movement of water inside and outside the cells. Usually, they are the preferred type of solutions which we use in terms of crystalloids. The next one is your hypertonic solution, where you have a higher solute concentration than the another solution, and the water particles will be moving out of the cell. So here you can see that because of this difference in the osmolality, the water molecule, the concentration of the water particles will be moving outside the cells, and because of which the cells will be shrunk. When we talk about the third type of solution, which is your hypotonic solution, so they have the solid concentration which is lesser than that of the blood plasma, and because of which the water moves inside the cells. So they will be leading to expansion, or you can say edema inside the cells, or the water inside the cells will also increase. So usually for the usual management, you go for the isotonic solutions. But in case of a person who is having, who is prone to have a severe hemorrhage, or who is having the cerebral edema, we prefer hypertonic solution. Also in hyponatremia, we may prefer hypertonic solution only. But if a person is having the fluid loss, that is because of vomiting, because of diarrhea, we might go for the hypotonic solutions. Or if a person is having hyponatremia, again we might prefer the hypotonic solutions. The next one is colloids. So colloids are again of two types. We can have natural colloids and we can have the synthetic colloids. So usually the colloids are not preferred one, but yes, in some cases, if they are indicated, we have to go for the colloids. Albumin is one of the main colloid which has been used, which is a type of natural colloids. And usually if a person is having ascites, or the person has gone, like the person has been, the pericentesis was done, abdominal tapping was done, there was a kind of fluid removal from the body, and so we have to replace the fluid with the help of the colloids, and usually we do it with the help of albumin solutions. Then the next one is the complication. So like we have seen that usually most of the times the patients are been put on the crystalloids or colloids, and we don't even like we are negligent towards to see whether the person needs to the fluids needs to be withdrawn or not, and because of which the patients are developing a lot of complications. The complications might be in terms of electrolyte derangements, like the person might have hypokalemia, the person might have hyponatremia. So it is very important that we are monitoring the blood electrolyte level of the patients, and depending on the values, we are again changing or modifying the fluids if it is needed or not needed. Then one of the another complication can be volume overload. So what might happen because of if we are not maintaining the rate of the fluids, if we are not maintaining the volume of the fluid, what might happen, the person might be having excessive fluids inside the body, which might lead to volume overload, which might even be very fatal for the person might be having cerebral edema, or the person might be having overall generalized anasarca and fluid overload. Then these people, if the management is not been done properly, these people might also get the compartment syndromes, and usually the persons might be getting the abdominal compartment symptoms, and because of which again the fatality and the morbidity also increases. Then these people might also have the metabolic acidosis because of the excessive use of the isotonic solutions even, or the use of normal saline even in these solutions. So apart from these complications, the other complications can also be there, like the person might have hematoma because of the presence of this IV access, and then displacement of the catheters and all. The person might have phlebitis or the thrombophlebitis. It might cause the air embolisms, infiltration, or extravascular or intraarterial infections. Sorry, it is infections. The person might be having the device embolisms also. So what is important is, from the nursing point of view, we have to we have to be using these fluids very judiciously, and for which we have one term which is known as fluid stewardship. So basically, the fluid stewardship is defined as a series of coordinated interventions for judicious IV fluid administration, so that we can limit the deleterious effect of the inappropriate fluid prescription, and also we can optimize the clinical outcomes. So in every hospital, we have to make sure that this fluid stewardship is being followed. And I'll just talk about the components of this program, so that the patients are getting the fluids which are actually required by the patients. We are not giving excessive fluids, and we are also not we are not also giving less volume or amount of the fluids to the patients. So in the fluid stewardship, we have a fluid team which includes a champion who is also known as IV fluid steward. We have IV fluid lead nurse, we have the prescribers, the doctors who have written the fluid for the patient, we have the nurses who are working for the patients, administering the medications and the fluids to the patients, we have the dietitians, we have the clinical pharmacist who is dispensing the fluids from the pharmacy, and we have the IT specialist who is maintaining the data. So every hospital, because these all people are not someone or who are extra in the team, they all are already the part of the healthcare team, but we need to have a dedicated fluid team, so that the complications which have been associated with the mismanaged fluids can be minimized. So if we talk about the roles and responsibilities of a fluid team, here I'll be concentrating on the nurses only. So we have in the fluid team, we had two main specialties of nurses, that is IV fluid lead nurse and the nurse who is taking care of the patients at bedside. So when we talk about the roles and responsibilities of the IV fluid lead nurse, she or he is able to is supposed to maintain and assess the ward-based practice. What is the practice there in the wards? What is the practice there in the hospitals or daycares or the ICUs? Which kind of fluids are being used? Whether they are maintaining the drop rates or not? Whether they are maintaining the fluid status of the patients or not? Whether they are doing proper monitoring or not? So that kind of assessment will be the key area for the IV fluid lead nurse. Then she or he will be delivering the point of care education sessions, because you know what happens, the patients or the nurses or the other people who are working there might not be knowing about the criticalities in the fluid management. So she or he will be assessing the need of education, and if required, she'll be providing the point of care education. Point of care education means then and there the teaching will be done, the correction will be done, the guidance will be done to that particular subordinate who is working with that patient. Then the person who is working as IV fluid lead nurse will be teaching and supervising the appropriateness of the fluid prescription. How much fluid has to be prescribed, whether it is appropriate or not. They'll also be maintaining or making sure that the appropriate fluid is been prescribed and is been administered to the patients. Then they'll be helping in recognizing and managing the complication. Like we talked about many of the complications which are associated with the IV fluid therapy. So the IV fluid lead nurse will be trying to recognize these complications as early as possible and manage these complications as fast as possible. And the person will also be training and teaching other healthcare workers other than the nurses regarding calculation of fluid balance and all. We know that the patient every hourly or every 2 hourly in the hospitals, the intake and output is being monitored. Usually, it is a very important step when we talk about the fluid management, because if we have the hourly or 2 hourly, or you can say day wise, the fluid data of the patient, like the person had the intake of 2000 ml and the output of 1500 ml, and depending on which we can calculate the balance, like the person had positive balance, the person had negative balance. And if a person is having the positive balance, it means there is a kind of volume overload, or there is a kind of retention, or there is a kind of edema. If a person is having negative fluid balance, it means the person might be in a state of dehydration. So these kind of small teachings and surveillances will be done by the IV fluid lead nurse. When we talk about the nurses who are the part of fluid team, usually no separate nurses will be assigned as a part of fluid team, but the nurse to whom the patient is been assigned will be a part of this fluid team, where the nurse is supposed to administer the fluids as prescribed. Though the patients will be given the instructions with, like in the medical records will be, or the physicians will be giving the instructions, like you have to provide 2000 ml or 1000 ml or 500 ml or 1 pint of the normal saline ringer lactate. So whatever is the prescription, the nurses will be administering them. You have to make sure that you are administering the same amount of fluids which have been prescribed by the prescriber. Then the nurses will be the person who will be updating the fluid balance charts, like we were talking about. They have to update the person is into the positive balance or the negative balance, or which kind of intake and output monitoring is been going on for the patients. The nurses will be doing it. And also very important point is they have to weigh the patients as per the hospital policy. So depending on the patient is in the ward, or the patient is in the ICUs, or depending on the ambulatory status of the patient can walk, or the person is bedridden. So depending on different factors, the nurses will be making sure that the patients are being weighed, because weight can tell you directly about the fluid retention. And if you're monitoring the weight every day, or as per your hospital protocol, or maybe every 7 days, you can have the idea that if a person is attaining, or the person is gaining a lot of weight in a very short period of time, the person seems to be edematous, there is pedal edema, there is anasarca present. So these all things might be alarming for the nurses as well as for the healthcare workers. So these are the main responsibility of a nurse who is working as a fluid team. And it is very important that the IV fluid lead nurse is also supervising the nurses, whether they are doing their work properly or not, in terms of what is expected from them from the fluid team. Then, as per the fluid stewardness, they have some principles of fluid prescription. So, these principles of fluid prescriptions are actually the 5 Ps, where we have the prescriber, the prescription, the pharmacist, the preparation, and the patient. When we talk about the prescriber, the doctor, they have to make a clinical decision regarding the fluid management. Okay, the patient needs the fluid, the patient is in volume overload, the person is in dehydration, you have to replace the fluid, you have to withdraw the fluid, how you have to manage the fluid, that kind of clinical decision will be taken by the prescriber. Usually when we do the such kind of clinical decision making in the ICUs, we keep different kind of parameters in mind. I'll just show you one of a few of them. Like we can, like, it again depends on hospital to hospital or ICUs to ICUs. So usually the central venous pressure is one of the parameter which has been assessed. Usually it has been done, but many of the institutes it is not also been done. So on the basis of CVP, you'll be assessing the person needs fluid or the person doesn't need fluid. So usually if a person has been put on the central line, he'll be placed with the transducer. If the transducer is not there, he'll be put on the water manometer, and where you'll be assessing the central venous pressure of the persons. If a person has a high central venous pressure, it might tell that the person is in the fluid overload. If a person is having the low central venous pressure, it might tell that the person might be in the hypovolemia or the person has the low blood volume. So depending on the central venous pressure values, you can just see the need of the giving the fluids or not. Same way, nowadays, usually we are using the IVC ultrasounds where we are assessing the diameter as well as the collapsibility of the intra your IVCs, inferior vena cava. So what happens, again, it depends on protocol to protocol. Every day also the IVC ultrasound might be taken, or it might vary from hospital to hospital. So usually what you see, the people will be doing the ultrasonography of the IVC ultrasonography, where they'll be assessing the diameter of IVC. Usually the inferior vena cava is 1.5 to 2.5 centimeter in diameter. Those people who have the volume overload, you might be having the IVC diameter of more than 2.5. If the person is having the depletion of the volume, or you can say dehydration, the person might be having the IVC diameter of less than 1.5. So depending on that, you can just see the need of fluid replacement or not. Same way, the collapsibility. Usually when the person is inhaling, when there is the person is inspiring, there should be there should be like what to say, the IVC should collapse. And depending on these two parameters, like diameter as well as the collapsibility, you'll be assessing the need of fluid replacement. आपको fluid देना है, नहीं देना है. And the third thing which we might use is the flow track system. Again, this kind of system will be requiring, like, it might not be cost effective, but yes, wherever it is indicated we might use it. So usually the flow track system is used for the hemodynamic monitoring of the patients, but if you are using the volume assessment also, or you can say the volume flow also along with the flow track, it can provide you the variation in the stroke volume. Here also you can see that, you can see the stroke volume variation, you can see the cardiac output, and depending on these parameters you can find out the person needs the fluids or the person doesn't need the fluid. So these are some of the examples the people might use in the ICUs, just to see there is need of the prescription or not. The second principle of the fluid prescription is prescription. So depending on the clinical judgment, now the prescriber will be writing the need of the fluid. They'll be writing about the drug, dose, and duration. So IV fluid is also considered as a drug. So they'll be writing which IV fluid, which dose, and for how long they have to give it. Then the pharmacist will be checking the appropriateness of the prescription, any inconsistency if it is there or not. In Indian setups, because pharmacists are not clinically involved in the patient care, even nurses might see for this kind of inconsistencies. The fourth principle is preparation, where the nurses are prescribing, the prescribed fluid is prepared by them, and any kind of electrolytes if it is needed. Many times you have to insert, you have to instill, or you have to infuse some other kind of electrolytes also. If there is any kind of indication for that, depending on the prescription, they'll be preparing the solution. And then the next or the fifth P is your patient, where the fluid is administered to the patient. The process, response, follow-up management are handled by the fluid steward. So these are the five things we have to keep in mind when it comes towards the fluid prescription. Then as per your fluid stewardness program, we have 7 Ds of the fluid therapy. 7 Ds includes definitions, diagnosis, drug, dose, duration, de-escalations, and the documentation, where you have to clearly define which kind of case will be requiring the fluids, what is hypovolemia as per your protocol, what is hypervolemia as per your protocol, what is replacement fluid, what is maintenance fluid, what is resuscitation fluid. These all kind of definitions will be there as per the protocol, as per the institutional guidelines. Then diagnosis, depending on the definitions which have been set, the patient will be diagnosed for the need of fluid replacement or not, and depending on those diagnoses, the drug, which is the fluid, will be prescribed, keeping the five principles of prescription in mind. The dose will be set as per that, the duration will be set as per the need of the patients. Once the patient has been put on a particular type of intravenous fluid therapy, it is also our responsibility that we have to observe for the de-escalation. de-escalation, like the person needs this fluid now also, or there is need of withdrawing the fluid, because if you are giving the fluid for a long period of time, the patient might go into fluid overload. So you have to see the need of de-escalation, and whatever is a finding, you have to document that. So whenever we talk about the fluid stewardness, it is important that we are talking about the principles of fluid therapy, and we're also talking about these 70s of the fluid therapy, so that we are using the fluids very judiciously for the patients, and we are preventing the complications which might arise because of the mismanagement of the fluid therapy. Then these three things I have discussed. Then the important thing is, what is a nurse's role in the fluid management or administering the fluids to the patient? So as nurses, we have to actively participate as a fluid management team. We have seen that the fluid management team includes the all of the healthcare workers who are directly involved in the patient care, out of which the nurses have very active role. So the nurses should be participating very actively as a fluid management team. Then it is important that usually we always do it, like depending on the criticality of the patients, the vitals will be monitored maybe regularly, maybe every hourly or 2 hourly, 4 hourly. So depending on patient to patient, it is like it depends on them. But yes, the monitoring of vital signs is very important, because if a person is going into hypovolemia, or is there any kind of fluid replacement required, you can see that on the vitals of the patients only. The patient's BP might fluctuate, the patient's map mean arterial pressure might decrease, the patient's heart rate, the patient's pulse pressure, they all might get affected. So you have to have a very close monitoring, very close watch on the patient's vital signs. Then we have discussed about this weight monitoring. Okay, the monitoring is very important, because that can tell you about the fluid retention, or it can also tell you about the dehydration of the patients, the volume depletion of the patient. So you have to have a record. Whenever you monitor the weights, you have to have a record, and always you have to have a baseline record also, and you have to compare the baseline record with the upcoming findings of the weight of the patients. Then intake and output is very important. Very precisely, the intake and output has to be monitored. If the person is having Follis catheter, the person is having the Euro bag, exactly you can find it out. At the same time, you have to make sure that if the person is taking any kind of, like the person is taking any kind of fluids, or the person has been put on any kind of fluid replacement therapy, or you are giving the medications, you're using the diluents. So whatever kind of fluids is been given, that should be properly documented. Then also you have to assess for the fluid balance, positive balance, negative balance, and if there is any kind of disparity happening, you have to report it. It is very important. It should prompt you, and you should take the prompt actions for that. Then if depending on the need of the patients, the fluids have been prescribed to the patient, so you have to make sure that there is a judicious use of fluids. Excessive fluid should be always prevented, because this will be putting your patient into more danger. So you have to make sure that you are using the fluids of the patients very judiciously. And it's also our responsibility being nurses, that we have to administer correct volume after calculation of the flow rate. So whatever fluid has been given to the patients, like the person has been put on 1000 ml of ring elected solution, suppose, per 24 hours. So you have to calculate the flow rate. Okay, if I have to give 1000 ml in 24 hours, how much fluid I have to give in 1 hour? And depending on which only, you have to set your flow rate. The fluids, again, it will depend on area to area. Like in the hospital, in the ward settings, in the general ward setting, usually the fluids will be given using your IV sets only. But if the person is in the ICUs, you might have to use the infusion pumps for giving the fluids, because we need to have very close monitoring of even a single ml of the fluid which has been gone inside the patient's body. It can also make a difference. So definitely we need to have more close monitoring when it comes towards the critically ill patients. And our work doesn't stop here. It is very important that we are reassessing the effect on the patients, whatever we have done. Like we have given the prescribed fluid, and we have to see that the patient's condition improved or deteriorated, what was the change in the vital signs of the patients, and depending on which, we also have to continuously see the need of de-escalations. And if it is required, we have to again alarm the concerned physicians that the person might not be requiring the fluids now, and they can They can also assess and see the need for any kind of de-escalation if it is needed. So that's it about the fluid, IV fluid administration. The next part is on the antibiotics, that is administration of antibiotics. So, antibiotics are the common agents which are used in the modern healthcare, and they are the compounds that target the bacteria and thus are intended to treat and prevent the bacterial infection. So, usually we use one term which is antimicrobials. Antimicrobials and antibiotics are interchangeably used, but actually they are different, because antimicrobials will be including any kind of microbes, be it the bacteria, be it the fungi, be it the protozoa, be it the viruses. But when we talk about antibiotics specifically, they deal with the bacterial infection. So antibiotics and antibacterials are same, but antibiotics and antimicrobials are not same. So the use of antibiotics started somewhere, the history of antibiotics started somewhere in the late 19th century, where we all know that Sir Alexander Fleming was the person who accidentally discovered the penicillin and who got the Nobel Prize also afterwards. And we saw that afterwards there was a long list of classification of antibiotics. And if we see in the modern era, at today's time, almost everyone takes an antibiotic, be it under the prescription or without any kind of prescription, which is very alarming. So before I go into all those kind of resistance and those kind of complications, let's briefly have a look on the antibiotics or classification of antibiotics. So the antibiotics, as we were just discussing, antibiotics are, now we have a long list of antibiotics, long classification of antibiotics, where we can have the antibacterial drugs or antibiotics, like who with the drugs which inhibit the cell wall synthesis, like you have the penicillins, you have the cephalosporins, carbapenems, monobactams, vancomycins, very commonly used medications. Then the antibacterials which cause the leakage from cell membranes, like polymyxin, colistin, are used. Then you have the antibiotics which inhibit the protein synthesis, like you have the tetracyclines, or you have the linezolid, or you have the clindamycin. The antibiotics which causes the misreading of mRNA, messenger RNA, and affect the permeability, like you have the aminoglycosides, gentamicin, streptomycin, etc. Then you have the antibiotics which inhibit the DNA gyrase, like you have the ciprofloxacin. The antibiotics which interfere with the DNA function, like you have the rifampicin, which is also the ATD drug. Then you have the antibiotics which interfere with the intermediate metabolism, such as your sulfonamides, sulfones, trimethoprim, etc. We have other lists also, like you have the sulfonamide group of antibiotics, where you have the short acting, intermediate acting, long acting drugs. And then you have the quinolone antimicrobials, where you have the first generation, second generation. Commonly we use this medication, levoflox, moxifloxacin, then your ciprofloxacins, norflox, oflox, etc. Then you have the penicillin group of antibiotics, where you have the natural penicillin, like your benzyl penicillin, penicillin G. You have the semi-synthetic penicillins, or you have the beta-lactamase inhibitors, like your tazobactam, sulbactam, etc. Then you have the cephalosporins, which have again first generation cephalosporin, second generation, third generation, fourth generation, where we commonly use these drugs, like your cefazolin, or your ciproxim, your cefotaxim, your ceftriaxone, cefexim. These are common cephalosporins which have been used in almost all kind of hospital settings, healthcare settings. Then you have the antibiotics which target the tubercular, your Mycobacterium tuberculi, which are known as anti-tubercular drugs, where you have the first line drugs, which are preferred, and then you have the second line drugs. In first line drugs, we have HRZD, that is your isoniazid, rifampicin, pyrazinamide, ethambutol. Then you have the second line drugs, where you can go for the levoflox, oflox, ethanolamide, kanamycin, amikacin, etc. Also, you have the drugs, anti-tubercular drugs, depending on group 1, which is your first line oral drugs or injectable drugs, fluoroquinolones, etc. And then you have the anti-leprotic drugs, which works under the leprosy, for the leprosy, like you have Dapsone, you have phenazine derivatives, you have other antibiotics, etc. So we have a broad list of antibiotics. Many of them must not be even covered in these presentations. But the thing is what? The thing is that we are not judiciously using the antibiotics also, and because of which only we are coming up with so many kind of resistances. So when we talk about the antibiotics, Usually, we use antibiotics as prophylactic therapy, use the antibiotics as empiric therapy, and we use the antibiotics as specific therapy. So, when we talk about the prophylactic therapy, before even we have diagnosed the patient's condition, before even we have identified the microorganisms which has caused the silent symptom in the patients, we start with the prophylaxis. Okay, the patient who is there in the hospital might get the nosocomial infections, and we start with the antibiotics. That kind of therapy is your prophylactic antibiotics. Or the person who has to undergo the surgery, because surgery possesses a lot of risk of infection, so we put a person under prophylactic antibiotics, which is again very important to prevent the patients from SSIs or surgical site infections. Same way we have the empiric therapy. Empiric therapy is the therapy which is based on the expertise or the experience of the physicians, where we have not diagnosed the person yet that this symptom is because of so and so bacteria or viruses, but we think that because most of the patients come with such kind of problems, and most of the patients this kind of therapy is effective, so why not to start with the beta-lactamase or the empiric therapy for that. Then comes towards a very specific therapy, where what happens, you have got the culture of the patients checked, you have found out that this infection is because of a staph species or E. coli, Klebsiella, whatever is the causative agent, and you're using the specific kind of antibiotic for that patient. So we might use these antibiotics under these three main classification, which is your prophylactic use, your empiric use, and your specific use. But the problem is the resistance. So the people, because I was just discussing also, sometimes it has been prescribed, so there is a kind of like it was not needed but it was prescribed, so you have taken it, and next time the person has got the resistance. But sometimes what happens, the patients take over the counter medications. Common cold hua, halka fulka जुकाम बुखार हुआ, and they started to have the antibiotics. Usually that is problematic. Why? Because WHO says that there is a term known as watchful observation. Now, some kind of infections don't even like not some, many kind of infections in the outpatient area settings don't even require any kind of therapy, any kind of antibiotics. But the patients are, because of the Google University, or maybe the peer pressure or the information which they get from the collateral sites, the people have started to use the antibiotics just for those kind of infections also, which can be treated on their own only. So WHO says that for such kind of infections, the watchful observation is important. Like we have to just observe the patients for a week or so, or 10 days. If there is the symptoms are been resolving, definitely the person doesn't need any kind of antibiotics. But yes, if the symptoms are not getting resolved, the person might need the antibiotics. So it will depend on case to case basis. But yes, in the hospitals also, many times because of the empiric therapy we talked about, or we talked about the prophylactic management also, the patient might go into antibiotic resistance. This resistance might be because the patient was already exposed to that, and now there is a kind of mutation in the bacteria leading to changes, and then the bacteria is not responding to the antibiotic where it is supposed to respond, which can cause the AMR. AMR is your antimicrobial resistance, but here I'll be talking about the ABR, which is your antibiotic resistance, the resistance towards the antibiotic which was started for the treatment. So how can we recognize the antibiotic resistance? You have started with the medications, but the patient is not getting relieved, the symptoms are not getting relieved, or you need to have a long term management. Or if the suppose initially you planned for a week of antibiotic shots, now you have to go for 1 more week. It means the person is getting resistance to the antibiotics, and for which it is very important that we are going for the antibiotic sensitivity testing, so that we can just assess the person's before the person develops resistance. Before that only we can just assess the person is sensitive towards some kind of antibiotics or not. But the main thing is we have to prevent any kind of antibiotic resistance. So that will be improving the antibiotic prescribing and use, which is effective for treating the infections. And also we have to see that we are combating with the antibiotic resistance, for which the WHO has given the categories of antibiotics. This category is based on the traffic signals. Like in the traffic signals, we have the green light, yellow or orange light, and the red light. Same way, the WHO has given 3 color codings in the categorization of antibiotics, where we have access, watch, and reserve kind of antibiotics. When we talk about the access classification, they have the narrow spectrum of the activities. They don't work against so many bacteria, but they have very narrow spectrum of activity. They work against a specific kind of bacteria only. They have low cost, they have good safety profile, and usually because of their good safety profile, they have a very low resistance potential. So WHO says that these kind of antibiotics might be safer options for the patients. Then the next classification, next category is a watch category, where it comprises of broader spectrum antibiotics. Usually they come with a higher cost, higher than the one which were there in the green access category. And usually they are the first choice options for those patients only who have more severe clinical presentation. If a person has mild to moderate clinical presentation of the infections, you can go for the green or the access category. But if a person has a severe clinical presentation, you have to go for the wash category, which are your broader spectrum antibiotics. And then the third type of category are the reserve categories, where they are the last alternatives. They are the last choice antibiotics, which are used to treat those kind of infections which are multi-drug resistant. So from the nursing point of view also, it is very important that we know about these three categories, and we also see which might be safer option for our patients, which might not be that safer, and which might be really very unsafe for our patients. And the few examples I have given here from each category, because we do them, we use them in our day-to-day clinical practice. Like in the green category, access site, access zone, we have amikacin, we have amoxicillin, we have augmentin, which is amox plus clavulanic acid. You have ampicillin, you have benzathine, benzyl penicillin, you have cefazolin, you have chlorphenicol, you have clindamycin, you have gentamicin, you have nitrofurantoin. There are a lot many other drugs also. Few of them which we use commonly in the hospitals, I have just jotted down here from the WHO site only. The second class of category, which is a watch category, includes azithromycin. So again, I would like to highlight here. Usually, patients have this kind of tendency to take azithromycin even in a very small kind of or common cold kind of condition also. But yes, this is again not very safe drug. Then your cefixime, cefotaxime, ceftriaxone, ciproxime, ciprofloxacin, clarithromycin, meropenem, vancomycin, they again come under this category. And the severe one, the red one, is the reserve category, where you have the colistin, which is your polymyxin E. Then you have the phosphomycin, and you have the linezolid. There are other drugs also, but these all you can just keep in mind. So you should know how to categorize them in these three kind of zones, and that should alert you that my patient is getting this kind of reserve kind of medications. I have to watch carefully for the complications, or my patient is getting yellow kind of watch kind of medications. I really need to observe the patient for any kind of complication. So that should alarm you depending on the categorization by antibiotics. Then, like we talked about the fluid stewardship, we have the antibiotic stewardship also. So, this is the effort to measure and improve how antibiotics are prescribed by clinicians and used by the patient. So, again, because antibiotics are very commonly used, antibiotic resistance is again very common phenomena, and we need to really be very we need to be very specific, very sensitive towards the use of antibiotics to prevent the antibiotic resistance. We have to follow this stewardship program to prevent the kind of misuse of antibiotics and the resistance which is associated with the misuse, for which you have there are 7 core elements given for the antimicrobial stewardship program, where you need to have the leadership commitment, accountability. The person who is prescribing the medication should be accountable, should be knowledgeable also, should have the drug expertise, should be prescribing the drugs only if it is indicated. Preventing any kind of resistance is very important. Taking the actions which are in the favor of the patients, preventing, minimizing the harm to the patients, tracking the use of antibiotics, for how many days a person has been getting them, and the tracking for any kind of complication the person is developing, any kind of drug interaction the person is having, then reporting any kind of ill effects if it is happening, or documentation is also important so that we can track it well. And then education, keeping ourselves updated, also at the same time educating our the colleagues, or educating the patients and the caregivers, because this also they are also misusing the antibiotics. So these are the main 7 core elements which are the part of your antimicrobial, which might be relevant to any other kind of drug also. But particularly for the antibiotics also. So, the role of nurses in case of antibiotic therapy, it is very important that, like when we talk to our patients, we usually take the history of the patients and do the physical examination of the patients in the very first or second meeting when we go and talk to our patient for the first time. So, it is very important that we are trying to obtain and document the history of penicillin allergy or antibiotic allergy, because many times what happens, usually it is not just the work of a physician, it is the work of all the healthcare team. So many times what happens, it might be missed from the physician point of view. So being nurses, it is your responsibility, if the patient has been assigned to you, that you are assessing the person for any kind of allergy he had with the antibiotics previously or not. Then many of the antibiotics required your sensitivity testing, specifically the medication which you have to give through the intravenous route. So it is very important that before you give the full dose, you are giving the test dose to the person. Usually the test dose is being given intradermally. You are giving a very small amount of the medications, 1 ml of the medications, zero point 0.1 ml of the medication has been given sometimes as your sensitivity dose, and then you are assessing the patient is getting any kind of local reactions there where you have given the sensitivity dose, and depending on that reaction, you have to give the full dose or not. That will depend on the sensitivity testing of the persons. Then if the antibiotics are being prescribed, you have to ensure that optimal antibiotic administration is there. You have to just keep in mind all the rights of the patient, rights of the drug administration. Right patient is there, right route is there, right dose is there, right documentation is there, right frequency is there. All those rights you have to keep in mind when, and you have to follow them also when it comes towards the administration, so that any kind of medication errors linked with the antibiotic use can be prevented, can be minimized. Also, we have to see that the person needs the step down therapy or not. It means, what if the patient has been put on the intravenous antibiotic use, but after sometimes you observe, because you are there with the patient 24/7, so you are observing the patient, that the patient is able to tolerate the oral feed, the patient is able to have the sips of water, the person can take something from mouth. So you can, that is the time you can alarm the physician that now the IV antibiotics can be stopped, can be shifted towards the oral route, because the IV antibiotics, IV medications poses their own risk of putting the person into more danger of having the infections. Then also you have to see, you have to prompt for the antibiotic timeout. Usually when we see in the hospitals, we monitor the day-wise use of antibiotics. Like if the person has been put on the colistin, this is 7th day of getting the person being the patient on colistin. The person has been put on the ceftriaxone 8th day. Usually in the nurses side only you're charting it every day. So you have to again alarm the physician that already the person has been put on 7 days of antibiotics, or already the 15 days are over, 10 days are over, the person needs time out from the antibiotics or not. That kind of healthy discussion should always be the part of the patient management in the hospitals. And very important part is patient and the community education. We are the educators, we are the advocates for our patients. So it is very important that we are telling the patients about the hazards of using the antibiotics blindly. The patient doesn't know about the indication, contraindication, drug interactions, and a term like antimicrobial resistance. So you all have this kind of you all can just talk to your patients and can get your awareness programs done in the community, where you are telling the patient that any kind of over-the-counter medication, specifically the antibiotics, should not be taken without any kind of prescription, because if it will be needed, actually the antibiotics might not work. So it is very important to teach our patients regarding that also. So here I complete the second part of our presentation. Now the third and the last part of my presentation is on the blood and blood product administration. So definitely it is again one of the job description of the nurses that we are we are administering the blood and the blood products to our patients. So there are a few things we have to keep in mind, which we'll be talking in this section. So there is a term, again it is by WHO only, the rational blood use. Rational blood use means that we are trying to reduce the unnecessary transfusions and minimizing the risk associated with the transfusion. The blood has been given to them only who really need it, and it is given in that dose only that amount only which is really required, so that the risk which is associated with the transfusion can be minimized. The use of alternatives to transfusion where possible can be done. Like many times we don't need to go for the whole blood product, we can just go for the a part of the blood product. So that has to be seen, and safe and good clinical transfusion practices are being followed, which include the patient blood management. So as per the WHO, being healthcare workers, we have to just make sure that there is rational blood use happening inside our healthcare facilities. So briefly about the basics, we are using different components of the blood in the hospitals. Like we might use the whole blood, but usually we don't use the whole blood. You use the part or the component of the blood, where we use the packed red blood cells or fresh frozen plasmas, FFPs, or you use RDPs, random donor platelets, or you use SDPs, single donor platelets, or cryoprecipitates, etc., depending on the need. If the patient doesn't require the whole blood, you can go for a part of the blood which is the requirement of the patient. So usually the RBCs or PRBCs will be given to the patients if a person has severe anemia, or if a person had a severe trauma, the person had a lot of bleeding because of which, or the person had blood loss due to surgery. So the PRBCs, it's been preferred in that case. Then your FFP, which is your fresh frozen plasma, will be given to those people who have the deficiency of the coagulation factors or the clotting factors, or if you want to replace the plasma loss which was there because of the massive bleeding, or because of the second third degree burns the patient had, or the person had the shock. To replacement of that fluid, you can give the fresh frozen plasma. Then the concentrates of the platelets can be given if a person is having a low platelet count, if the person has the thrombocytopenia, the dengue was there, dengue hemorrhagic fever was there, or the person had bleeding because of these factors. In a nutshell, if you would like to correct the platelet-related problems, and the cryoprecipitates will be given to the people who have the fibrinogen deficiencies. The fibrinogen is not there in the blood; it is deficient, so you can go for the administration of the cryoprecipitate. So, if you know about the exact need of the blood component, you'll be saving a lot of blood, and you'll be using the blood and blood products very judiciously, which will be helping the person to prevent from the complications. And also the blood can be used in some other persons who really need it at that time. So to be very precise, in the ICUs we might use some other testing also, like you can use the TEG and the rotam. I don't know whether you have heard about, many of you might have heard about this also, might be using your ICUs also. Your TEG is your thromboelastography, and rotam is your rotational thromboelastometry. So usually they are the point of care assessment machines, where you what you do, you just try to find out the strength of the clot. So they are the different tests. Some hospitals, some ICUs, you might use the TEG only, some ICUs you might be using the rotam only. Usually the transplant ICUs or the surgical ICUs, they are being used commonly, because you need to see exactly which component is missing and exactly what you want to replace. So basically what the basic principles of this TEG and rotam is, they try to see the dynamics of the clot, the time which has been taken for the platelets and fibrin to come together to make a clot, then to see what is the strength of that clot, and then also see how much time it will take to get the clot to be lysed, what is the clot lysis time. So depending on a beautiful graph which you get out of both TEG and rotam, depending on which you see that the person is requiring plasma, the person is requiring the platelets, the person is requiring the fibrinogen, the person is requiring the clotting factors or not, because that will be ensuring that the exact deficiency can be treated with the help of administration of the exact blood product which is required by the patient. So these again, if it is available, you should be aware about the graph formation, and how to read that graph and how to interpret that graph, and depending on which you can replace the deficient component of the blood. So if not taken care of, or even if taken care of also, the person might get the transfusion reactions. Like you can have the acute transfusion reactions, or you can have the delayed transfusion reactions. When we talk about the acute transfusion reactions, which happens in a very short span of time, the person might have mild allergies or anaphylactic reactions. They can be febrile illness, which is non-hemolytic. They can be acute hemolytic transfusion reactions, and they can be TECO and TRELI. TECO is transfusion associated circulatory overload, which happens because of excessive replacement of the fluid, and because of which the person has overload, and this is again like causing a lot of trouble to the patients. Or you might also get the TRALI, which is your transfusion related acute lung injury, which might again happen as the transfusion reaction. When we talk about the delayed transfusion reaction, the person might be having a delayed hemolytic transfusion reaction, or there might be a transfusion associated graft versus host disease. So and the nurses should also be aware about these kind of reactions, because it is our responsibility to identify them as early as possible, and to withhold the this blood product if it has been recognized, identified, and to report it properly and to manage the patient. That is also very important. So the responsibility of the nurse in administration of blood and products will include that the nurses should know which blood component are appropriate for specific client situation. Like we talked about rotam and we talk about tech, we talk about different components of the blood. So nurses should have this kind of information that if my patient is requiring the cryoprecipitates, or the patient is requiring the FFP, or the person is requiring the whole blood, that kind of indications you should be knowing about. Then we have to just make sure that the signed informed consent is been taken from the patient. Usually the signed informed consent has been taken by the physician, but yes, you also have to see that it is actually taken, and it is also there in the file of the patients. Then we have to see the typing and compatibility screening. It is very important, because these kind of transfusion related reactions can be prevented if we are actually having a good compatibility screening, cross matching. So it is important to ensure that. And it is also important that we are doing the diligent patient identification and the blood product compatibility verification. Usually it is a two-person verification process, where the two persons are verifying the type of product which has come from the blood bank is the same which was ordered, the same patient has been given to that, and the kind of compatibility testing and all. So it is very important that we are following all this kind of verification process in order to prevent the kind of reactions in our patients. And usually you should also keep in mind that the blood is stored within a refrigerated area, and they are not these blood products are not never heated in a microwave or hot water, or they should never be vigorously shaken, because if you are shaking it vigorously, it will destroy the blood cells. And the cryoprecipitates, your FFPs, the fresh frozen sorry, your cryoprecipitates only, they will be it is important that you are thawing them before you are using it on the patients. So and in some cases you might have to give the warm fluid to the patient, but again it will not be applicable everywhere, and if it is indicated, then only it has to be done. So that's it for today. We have discussed about three main aspects, that is administration of intravenous fluid therapy, administration of antibiotics, and administration of blood and blood products. It is very important that we have the basic information, and we also updating our information about our knowledge in terms of these things, because the information, the knowledge is changing every day. These kind of things like your antibiotic stewardship or your fluid stewardship, any kind of changes which is happening in the standards in the protocols should be like the nurses should be aware about all those kind of things, so that we are minimizing the risk and the complications in our patients, and we can improve the clinical outcomes of our patients. So that's it from my side. Thank you so much.
Thank you, Tarika. I think it was an excellent presentation. You summarized all the three topics very, very well. And as I always say to my nurses also, that their role in ICU is, much more important than us. And they should know about what drug they are giving, what IV fluid they are giving, what is the implication of the blood product transfusion, and antibiotic stewardship, as you nicely mentioned, rightly mentioned about the stewardship. It is so important in today's world where the resistance is increasing day by day. So thank you so much. I think it was an excellent class. Thank you so much for joining us today on Young India Intensivist webinar. Hope to see you next week. Thank you.
Sure. Thank you so much, Dr. Monalisa. Thank you.